Hello, my name is Kimmy Haber, and this presentation will cover eating disorders across the lifespan. This presentation is for the Department of Nursing at Rockhurst University for the class NUA 5550, Psychopharmacology for Advanced Practice in Psychiatric Nursing, instructed by Dr. Amy Dunham, brought to you on this lovely fall day, October 5th, 2025. Introduction. Eating disorders are serious mental health conditions characterized by disturbances in eating behaviors and related thoughts and emotions that significantly impair physical health and psychosocial functioning. Common types include anorexia nervosa, bulimia nervosa, binge eating disorder, restrictive eating disorders, and other specified feeding or eating disorders, OSFED, each with distinct diagnostic criteria under the American Psychiatric Association guidelines. In the United States, eating disorders are relatively prevalent and affect individuals across genders, ages, and socioeconomic backgrounds. Epidemiological studies estimate that approximately 0.5 to 3% of adults experience anorexia nervosa, 1 to 2% experience bulimia nervosa, and 2 to 5 experience binge eating disorder at some point in their lifetime. Early recognition and treatment are critical as eating disorders are associated with substantial morbidity and increased risk of mortality. Restrictive eating patterns, including ARFID and atypical anorexia, occur less frequently than binge-type eating disorders, but are often underrecognized, with the prevalence rates in clinical populations estimated to be at 1 to 5%. Anorexia nervosa involves persistent restriction of energy intake leading to significantly low body weight relative to age, sex, and developmental trajectory. It is accompanied by an intense fear of gaining weight or becoming fat and a distorted perception of body weight or shape. There are two types: the restrictive type, limited food intake, and the binge eating purging type, restriction plus binging or purging behaviors. Bulimia nervosa is characterized by recurrent episodes of binge eating, consuming an unusually large amount of food with a sense of loss of control, followed by inappropriate compensatory behaviors such as self-induced vomiting, misuse of laxatives, fasting, or excessive exercise to prevent weight gain. These behaviors occur at least once a week for a period of 3 months and are associated with an overconcern about body shape and weight. Binge eating disorder. They are defined by recurrent episodes of eating large quantities of food in a discrete period, accompanied by a sense of loss of control and marked distress. Unlike bulimia nervosa, binge episodes are not regularly followed by compensatory behaviors. These episodes typically occur at least once a week for 3 months. Restrictive eating disorders and ARFID. Restrictive eating disorders are characterized by severe limitation of food intake that leads to nutritional deficiencies, weight loss, and potential medical complications. These include restrictive subtype of anorexia nervosa and other less specific restrictive patterns not meeting the full criteria for anorexia or bulimia. The behavior is typically driven by intense fear of weight gain and a preoccupation with body shape, or an aversion to food. Eating disorders have many etiologies. They arise from a complex interaction of biological, psychological, and sociocultural factors. Biological contributions include genetic predisposition, neurobiological abnormalities, and alterations in neurotransmitter systems, such as serotonin and dopamine, which increase vulnerability to disordered eating. Psychological factors including perfectionism, low self-esteem, body dissatisfaction, and difficulties with emotional regulation further increase the risk. Sociocultural influences such as societal emphasis on thinness, exposure to media promoting unrealistic body ideals, and family dynamics that reinforce dieting or weight concerns also play a significant role. The interplay of these factors can lead to maladaptive eating behaviors, perpetuating cycles of restriction, binging, or compensatory actions. Bulimia nervosa involves recurrent episodes of binge eating, followed by compensatory behaviors such as vomiting, laxative use, fasting, or excessive exercise. Physical signs may include dental erosion, electrolyte imbalances, and calluses on the knuckles. Behaviorally, patients may eat in secret and experience guilt or shame after binging. Anorexia nervosa is characterized by persistent restriction of energy intake, leading to significantly low body weight, intense fear of weight gain, and a distorted body image. Physical signs may include bradycardia, hypotension, amenorrhea, and cold intolerance. Behavioral features often include calorie restriction, excessive exercise, and food rituals. Binge eating disorder. Binge eating disorder involves recurrent episodes of eating large amounts of food with a feeling of loss of control accompanied by marked distress, unlike bulimia nervosa. These episodes are not followed by compensatory behaviors. Other symptoms may include eating rapidly, eating until uncomfortably full, eating alone due to embarrassment, and feelings of guilt or shame about eating. Restrictive eating disorders, RFID. Restrictive eating disorders are characterized by persistent limitation of food intake, leading to nutritional deficiencies and weight loss. Symptoms may include avoidance of certain foods, rigid eating rules, fear of weight gain, preoccupation with body shape, fatigue, and/or other physical complications from malnutrition. These patterns may occur in the context of anorexia nervosa or other less specific restrictive representations. RFID is marked by restrictive of food intake leading to weight loss, nutritional deficiencies, or dependence on supplements, without concerns about body image. Common presentations include a limited variety of food, sensory sensitivity, or fear of aversion consequences such as choking or vomiting. Patients may be underweight and experience anxiety around eating. Bulimia nervosa first-line treatment is cognitive behavioral therapy, typically delivered weekly over 20 sessions, focusing on normalizing eating patterns, addressing maladaptive thoughts about weight and shape, and reducing binge purging behaviors. Pharmacologic treatment can be added when indicated. Fluoxetine is the only FDA-approved medication recommended at 60 milligrams daily, with treatment usually continuing for at least 3 to 6 months after the symptom remission. Anorexia nervosa first-line treatment is family-based therapy for adolescents delivered weekly over approximately 6 to 12 months, or enhanced CBT/CBTE for adults. Nutritional rehabilitation and careful medical monitoring are essential. There is no FDA-approved medication for core anorexia symptoms. However, SSRIs may be considered after weight loss restoration to treat comorbid depression. There is a list right there in the PowerPoint for you to see as well. Binge eating disorder, CBT, delivered weekly for 16 to 20 sessions, is first-line therapy for binge eating disorder, focusing on reducing binge episodes and improving emotional regulation. Pharmacologic options include lisdexamfetamine, starting at 30 milligrams a day, titrated up to 70 milligrams a day, and SSRIs such as fluoxetine up to 60 milligrams a day when it's indicated. Medication is typically continued for several months with regular monitoring for efficacy and adverse effects. Restrictive eating disorders first-line treatment involves individualized psychotherapy, often CBT or guided self-help approaches, delivered weekly over several months, combined with nutritional counseling and medical monitoring. Pharmacologic interventions are generally considered only for comorbid conditions such as anxiety or depression, rather than for core restrictive behaviors. Advances in research. Research and clinical advances in eating disorders focus on improving treatment outcomes through pharmacologic, psychological, and integrative approaches. Evidence supports the use of selective serotonin reuptake inhibitors, SSRIs, particularly fluoxetine for bulimia nervosa, and emerging pharmacologic agents for binge eating disorders such as lisdexamfetamine. Cognitive behavioral therapy remains the first-line psychotherapeutic intervention for bulimia nervosa and binge eating disorder, while family-based therapy is particularly effective for adolescents with anorexia nervosa. Neurobiological research has identified alterations in reward processing and neurotransmitter pathways, which may inform novel interventions for targeting dysregulated appetite and impulse control. Additionally, clinical guidelines emphasize early detection, individualized treatment planning, and integration of medical monitoring to reduce morbidity and mortality associated with the restrictive and binge eating disorders. Because there's so many different eating disorders, I wanted to do a case study for each. The first one is Samantha, a 23-year-old female presented with recurrent binge eating followed by compensatory behaviors such as self-induced vomiting 4 times a week. She met the DSM-5-TR criteria for bulimia nervosa, with behaviors occurring at least once per week for 3 months. Treatment included her starting fluoxetine 60 milligrams a day, which partially reduced binge purge episodes but caused nausea, and initial anxiety from the weight gain, which led to some non adherence, even though SSRI side effects were discussed prior to starting. Topiramate was later trialed off label, which produced mild improvement, but compliance was limited by cognitive slowing and paresthesia. She underwent CBTE for 20 weeks, focusing on normalizing eating patterns. She increased her medication adherence, and that ended up reducing her binge purging behaviors and addressed her maladaptive thoughts about shape and weight. Compliance was hindered by emotional ambivalence and stress, and therapy occasionally caused emotional distress. But after 6 months, of binge purge frequency decreased to once per week, which is an improvement from her initial 4 times a week, with improved mood and body image awareness. Anorexia nervosa. Emma, a 19-year-old female, presented with severe restriction of energy intake, intense fear of weight gain, and distorted body image, consistent with DSM-5 criteria for anorexia nervosa. She required nutritional rehabilitation, the cornerstone of treatment, which was also supplemented with enhanced cognitive behavioral therapy, CBTE, focusing on cognitive distortions and gradual weight restoration. Pharmacologic interventions are generally adjunctive, so SSRIs such as fluoxetine may be considered for comorbid depression or anxiety once weight is partially restored. However, Emma showed no signs of comorbid depression and refused to take any medication for her anxiety regarding her weight gain. Compliance challenges included fear of weight gain, food-related anxiety, and rigid perfectionism. Over 6 months, Emma gradually increased caloric intake, gained weight, and reduced preoccupation with body shape, although ongoing CBTE therapy was required to maintain progress and is still needed. Binge eating disorder. Alex is a 32-year-old male presented with recurrent episodes of eating large amounts of food with compensatory behaviors meeting the DSM-5 criteria for binge eating disorder. Psychologic treatment included lisdexamfetamine 30 milligrams a day, which reduced binge frequency but caused mild insomnia and dry mouth. CBT for BED over 16 weeks focused on identifying binge triggers, emotional regulation, and structured meal patterns. Compliance challenges included work stress and emotional avoidance, which occasionally limited effectiveness. Lisdexamfetamine was then increased to 50 milligrams a day with no adverse reactions or side effects at 7 weeks. After 12 weeks, binge episodes decreased significantly, and Alex reported improved mood and self-control around eating. Therapy will continue until the 16th sessions to reevaluate effectiveness and the need to continue therapy. Avoidant restrictive food intake disorder and ORFID. Liam is a 12-year-old male presented with restricted food intake leading to significant nutritional deficiency and weight loss without body image disturbance consistent with DSM-5 criteria for ORFID. Treatment focused on nutritional rehabilitation and family-based therapy, emphasizing exposure to new foods and structured meals. Pharmacologic interventions are typically adjunctive. SSRIs or appetite stimulants can be considered for kids for comorbid anxiety or severe avoidance. He was started on fluoxetine for comorbid anxiety and depression. He was at 10 milligrams a day, which can be titrated up. He was also placed on an appetite stimulant, antihistamine, cyproheptadine 0.25. Some compliance challenges included sensory sensitivities, fears of choking, and resistance to trying new foods. No side effects noted. Liam's mother stated he has been eating more with the stimulant and has less anxiety with the fluoxetine when it comes to trying new foods. After several months, Liam expanded his diet, improved his weight, and reduced anxiety around eating. Here's the reference and size used. Thank you guys.